just so we can post to our YouTube channel after this.
And so we're very thankful tonight to be spotlighting physical therapy with Elizabeth Sargent and Allyson Muehlemann. And so we'll let Elizabeth start and take it away, sharing her inspiration into medicine.
All right. Well, hi, everybody. I was going to say nice to see you, but I can't see anybody. So thanks for coming. My name is Elizabeth Sargent, Dr. Elizabeth Sargent. I'm a physical therapist. And, I found my way to physical therapy through a couple of different pathways. I was very interested in going to medical school. But my mother was also a physical therapist. So I had early exposure to the field. And back in the 80s, when I was in high school, medical school was financially out of reach. And so I was told that if I wanted to be in some sort of clinical medicine type of patient care role, I needed to find something that would enable me to get there in 4 years of undergraduate education. So at the time, physical therapy degrees, the entry-level degree was a bachelor's. And I graduated in 1993 from the University of Wisconsin. So yeah, sorry, I'm just going right into the next slide. And was able to start treating patients. I was very young. I'm kind of young for my sort of graduating year. So I ended up treating patients as a 21-year-old. I very quickly realized as a very young clinician that I needed more information. And so in the mid 90s, there was a transition from the 90s until the early 2000s. There was a transition in physical therapy entry-level education, in that it went from a bachelor's to an entry-level master's, and then quite quickly to a clinical doctorate. So now all physical therapists are graduating with a clinical doctorate in physical therapy. So they're doctors of physical therapy. They're typically 3-year programs. There are some accelerated 2-year programs, but generally it's a post-baccalaureate degree. So my master's at UVM kind of started to boost me in that direction. And then I was a practicing clinician for about 12 years before I decided I still needed to know more. And I think my inspiration for wanting to go back for my SCD, I found my way there through a fellowship in orthopedics. And so when I started looking at the SCD program, which is an SCD is, a lot of people are not familiar with that degree. It's a PhD equivalent. It is an academic doctorate complete with a dissertation. And SCDs in this country tend to be a little bit more clinical. And so a lot of practicing clinicians can kind of get that academic doctorate and have it be very clinically applicable. So in 2015, I ended up completing my SCD in rehabilitation science. And at the same time, became board certified in orthopedics and fellowship trained. And so in a pretty short period of time, I upped my game and got all the credentialing I possibly could in my field. And now there are no more degrees. So I don't know if you want to go to the next slide. Sure. So that's kind of a winding path of the last 30 years. Most of my time has been spent in an outpatient orthopedic setting, which means that particularly now in 2022, physical therapists are primary care providers. We can see patients without referral from any other provider. Our physician colleagues are there for referral back and forth if we need it, if we find something outside the scope of our care, or sometimes physicians and orthopedists and neurologists, physicians of all different types will refer to us for physical medicine piece. And you'll hear more of that from Allie as well, from Dr. Muehlemann as well. But primarily I've been in outpatient orthopedics. So that means that I know, some are interested in kind of what a typical day looks like. And generally what that means is that I'll have ideally 8 or 10 patients scheduled every day. And I'm sometimes the first point of care for whatever their musculoskeletal complaint is. It's a lot of neck pain and back pain and shoulder pain and those kinds of things. I will see post-operative patients, or I'll see pre-operative patients. And, we can determine a plan of care where we're seeing patients once a week, once a month, 3 times a week. It's really up to our discretion. And it's incredibly rewarding because it's very much,
Okay.
Go ahead. Did somebody say something? I thought somebody had a question. So it's very much, it's very collaborative. It has become more and more collaborative as the profession has evolved. So just understanding what a patient's goals are, understanding their quality of life and what kinds of things they need to help restore maximum quality of life or optimal quality of life for those patients. But the kind of the end of that trajectory, that career trajectory, is that with my academic doctorate, it also positioned me well for a faculty position. So I am now full-time faculty in the Doctor of Physical Therapy program at the University of Vermont. So now I'm primarily teaching. I still am in clinical practice, but the majority of my time is teaching students, and I teach musculoskeletal examination and management. I teach biomechanics. So there are a lot of different things that I teach. Yeah, so I think, I spoke a little bit about what it's like to function as a clinician. And I think that would be where I'll spend a little bit of time now is, when a patient comes to a physical therapist for the first time, in an outpatient setting, oftentimes, unless they come with an operative report or maybe an imaging report, you're really starting fresh with just trying to gather information from the patient about what their limitations or pain complaints or problems are, and having to be a little bit of a detective. So coming up with a hypothesis or an idea of what the diagnosis is, and then designing a clinical exam to uncover what their impairments are, what their limitations are, and using that clinical exam to guide our reasoning in terms of coming up with a reasonable diagnosis. Our clinical exam has actually been shown to be among the most accurate clinical exam of most providers for patients with orthopedic problems. We have more training than most physicians do in medical school. So in terms of diagnostic accuracy, PTs are kind of at the top of the list there. And then based on what we find in the clinical exam, we design a plan of care. So oftentimes it's going to involve exercise, and that exercise can involve strengthening, endurance, conditioning. It can involve neuromuscular training, things like balance and agility, reaction time, and really just using movement to promote physical activity and health and wellness, and facilitate tissue healing if that's what we need to do. So that's really kind of in a nutshell what the responsibilities are. In addition to that, I'm sorry, I'll add one more thing, is that we do a lot of communicating between physical therapists and other disciplines. So communication piece, to be part of that primary care team, it means we're communicating with physicians, we're communicating sometimes with dietitians, social services, nursing, all those other disciplines, to really provide the best the best possible care for the patient. So now we can talk about what I do for fun. So I live way out in the country and love to do all kinds of things outside. And so one of the nicest things about being a physical therapist is that it encourages lots and lots of movement. I'm moving most of the day, which is great because that suits me quite a bit. I love being in Vermont. I'm not from here originally, so I'm right up here in the mountains. I can see Mount Mansfield from my window. And I love to ski and hike and climb and run and do all those things. So
Thank you so much. And next we'll be hearing from Dr. Allyson Muehlemann and her inspiration into this field of healthcare.
And as a quick reminder, we'll have a Q&A session after this. So if people have questions, they can pop them in the chat and we will get to them after.
All right. Hi, everyone. Thanks, Elizabeth, for kicking that off. It's nice to be here with you guys. My career path is a little bit different than Elizabeth. Mine, I've always wanted to be a PT. I had an injury in middle school. I was a soccer player, and it was like my first game of the season in 7th grade, and it was like the first 10 seconds, and someone kicked through my shin guard, and I shattered my tibia, which is the biggest bone in your shin. And so I didn't get to play that season in soccer, which was really sad. And so I had extensive PT. It probably was about 4 months of rehab. And I just loved the relationship I had with my therapist. They were really inspiring and really got me back to playing soccer, which was ultimately my goal. And so ever since then, I really had wanted PT, and that's kind of how I got into the profession originally. And I just love the idea of forming relationships with people and being able to help get people back to what they love to do, since I had personal experience with that. And so for a while, I had always wanted to do sports, right? So if you choose the career path of PT, most students enter the profession wanting to treat athletes. And then a very small percentage actually end up doing that. So that's what I went to school for. And then I kind of played around with it a little bit and kind of took a different career path. But that's kind of my main inspiration. So I went to school in 2010. And so there are some programs, and they're kind of all over the country. I think they're a little bit more common on the East Coast, but I did a direct admit program. So at Damon College, that's in Buffalo, New York, and it was, if you enter the profession as a freshman, knowing that's what you want to do, you can get your bachelor's in 3 years. So I did a 3+3 program, all at Damon College, and it was 3 years of undergrad. So I technically have a bachelor's in biology, and then I did 3 years of grad school where I got my clinical doctorate of PT. And actually, what prepared me for PT school, honestly, the biggest thing for me was I had wanted it, right, for so long. And I really had a thirst to prove myself. I went to a college fair my junior year of high school, and they told me I wasn't smart enough because my SAT scores were so low. And so I really took that time to reflect on what I wanted to do, and I kept coming back to PT. And so I was very determined to prove myself, not only to myself, but to other people, that I could actually get through the program and make it through. And I didn't add it on here, but I guess I actually am also in school right now. So I'm going for a different terminal degree than Elizabeth, but I am going for my EDD, which is your educational doctorate. So I'm in school to get my degree, education and leadership, with a specialization in higher education. So that's kind of my education background. So my career path. So when I started out of PT school, I worked at an outpatient orthopedic clinic where I saw a lot of low back pain and neck pain, and I did that for about a year, and I didn't really enjoy it, and I wanted to try something new. So I moved to a different state. I moved to Minnesota, and spent a couple years out there. I worked in a really, really small hospital. There was only like 3 PTs, which was actually really fun. I got to meet a lot of great people in a small area. And then after working for a couple years, I kind of realized that I wanted to specialize. So the nice thing about PT is you can get a general PT degree, but then you can go on to specialize. So Elizabeth specializes in orthopedic conditions. And so I actually went the neurologic route. So I did a neuro residency in Minnesota, and I did that for about a year, where I kind of just spent the year working with individuals with neurologic diagnoses, stroke, spinal cord, multiple sclerosis, Parkinson's disease, ALS, traumatic brain injury. So I got to spend the year just really kind of immersing myself in that patient population. And then I sat, you can sit for a board exam after your licensure exam. So I sat for my neuro certified specialist board exam. So I got licensed a couple years ago. So I did that, and then I came back to the East Coast, and I'm originally from Syracuse, New York. So I moved to Rochester, New York, because it was close to home. And I worked at the University of Rochester Strong Memorial Hospital, and I was primarily an acute care therapist as well as an inpatient rehab therapist. So I kind of do more of the inpatient side of things. When you talk about acute care, that's more, like in the hospital when you're treating like in a hospital room, you're kind of going room to room, versus inpatient rehab, where they're actually coming to the gym and they're really there for therapy, and you're trying to get them home. So I did that, and then I've always wanted to teach, and I was kind of working on some teaching while I was in Rochester, and the opportunity came up for me to kind of come visit Vermont for the year. So I'm actually a visiting clinical assistant professor here at the University of Vermont, where I primarily teach in the neuro coursework, but I'm kind of helping out all over. So that's kind of my career path to this point. So I'll talk about the responsibilities just because it's a little bit different. When you talk about outpatient PT versus inpatient PT. So when we talk about acute care therapy, we're more like a consult service. So typically when you work at a hospital, whether you're a PT, an occupational therapist, a nurse practitioner, we really come in and we consult. We're consulted on our services. And so the big thing for PT, right, is if you have a patient in the hospital, it's our job to kind of assess how they're doing moving around to see if they're actually safe to go home or not. So the physician will kind of put in orders for the PT to see the patient. We'll get the patient up out of bed and kind of determine, yes, this patient is safe to go. These are the services that they may need, or no, the patient can't go home, and this is what we're going to recommend. And one of those recommendations is actually inpatient rehab, which is kind of the other piece of where I work. And that's, where you have patients go. They're medically stable. They're no longer considered in acute care in the hospital, but they go to a place and they stay where they'll go and they'll get, usually 3 hours of therapy, physical therapy, occupational therapy, and/or speech therapy. And really the goal of inpatient rehab is to get the patient stronger in order to get them home, right? So working on things like getting in and out of bed, transferring to and from a wheelchair, walking, room to room distances. So those are kind of the big goals from an inpatient rehab side. And Elizabeth mentioned this earlier, and I'll reiterate it, especially on the inpatient side, it's really important, is this idea of multidisciplinary approach, teamwork. You're really a team. Even though we kind of do our own thing, we can't do what we do without the input, collaboration from a lot of other disciplines. So that's really the big responsibilities. It's kind of fun being in a hospital setting. You get a lot of PT students. So I've had a lot of PT students, as well as actual residents who are there specifically for neuro patient populations. But yeah, those are kind of the big ones. So work-life integration. So when we talk about, me, obviously I'm not a full-time clinician anymore because I just transitioned into full-time faculty, but I feel like you guys kind of maybe want to know a little bit more about the clinic side of things. So when I was a full-time clinician, right, when you work in acute care, typically it's 5 days a week. I had a couple of jobs where I did 4 10-hour days. Traditionally for PT, they kind of want you there 5 days a week for 8 hours. Usually any hospital setting that you work at or any rehab setting that you work at, there's usually some kind of rotating weekends where you'll get kind of 1 weekend a month you have to work and help out there. And then as a full-time faculty, so I am, Elizabeth and I are both clinical faculty, which means that our primary role is teaching. And then we also have a certain amount of time that we spend continuing to treat patients. So I'm in the clinic once a week, and I will actually be at UVMMC in the acute care. And for fun, so I am not a Vermont native, but as either, but very excited and happy to be here. I also really enjoy the outdoors, really enjoy hiking, kayaking, and I am an avid reader when I have the time. So I love to read anything and everything. So I think that's it.
All right, we will move on to our Q&A. And so there's a couple questions in the chat. Just to begin, someone wanted to know, is pediatric physical therapy something someone can specialize in?
Yes. So, like I said, you can when you get your PT degree, right? You have entry level with all skills: pediatric, orthopedic, neuro, cardiopulmonary. But then a lot of PTs will decide to go on for more schooling, like Elizabeth went on to get more specialty in orthopedics, where I went on to get more in neurologic conditions. The same goes for pediatrics. You can actually get certified in geriatrics, cardiopulm, sports. Anything else I'm missing, Elizabeth? Or
Pelvic health, acute care,
pelvic health, women's health, yes.
I'm sure there are more.
I think those are
Those are the main ones.
And
Oh,
kind
hand
of.
therapy. You can be a certified hand therapist.
Oh wow,
Mhm.
that's so
That is true.
interesting. I think there's another question in the chat that I think is relating to this as well. When you are specializing, is that more, if I'm understanding this question correctly, is there more schooling in a sense, or is it more like kind of clinical based hands-on? Or are you also, in addition, taking coursework?
Yeah, you can get there 2 different ways, and it's perfect because Allie got there one way, I got there the other way. So I think the best way to get there is through a residency. And so a residency essentially is a 1-year fast track to your board certification. And there is a classroom or didactic component to that. And essentially what you do is you're in school part-time and then you're in clinic part-time. And so you get both the classroom and the clinical mentoring. And then at the end of that, you sit for your board exam. So do you want to add to that? Oh, well, and then the other way is what I did, which is you're a PT for a really, really, really long time. And you just accumulate enough miles and do a lot of studying that it enables you to sit for the exam. It's harder to do it that way. I wouldn't recommend it because a residency is so well structured and you get so much out of it. And there's actually mounting evidence to show that PTs who are residency and fellowship trained are actually resistant to burnout and have higher job satisfaction. And that's pretty well documented.
Yeah, I'll just add one quick thing because I think you did a nice job summing it up. So basically, I went to school and got my doctorate of PT. So that was 6 years. For most people, traditionally 7 years, and then you would go on for another year. So I had a total of 7 years technically schooling. So it's kind of similar. It reminds me of like a lot of when you get your MD, right? So physicians have to go on to their residencies, but they're already doctors. That's very similar to how the PT is structured.
Right.
Thank you. And another question from the chat. In inpatient rehab, on average, how long would you be working with any given patient before they go home? And so they want to know the range, as in the shortest amount of time you work with patients and the longest amount of time.
Yeah, so traditionally, the role of inpatient rehab was to get patients to go home. So when inpatient rehab first started, it was you went to inpatient rehab and you stayed there until you went home. So if you have a patient with spinal cord injury, you could have a patient there for months, right, with the ultimate goal of getting home. That is not the case anymore, right, because insurance dictates a lot of what we do as PTs, unfortunately. And so now we are very, very time constricted. So I would say the average is now about 2 weeks. So insurance companies will give patients about 2 weeks to get them home. I mean, obviously there are circumstances where patients are there longer. I would say between 2 and 3 weeks is probably average nowadays for inpatient rehab. Was there a second part of that question? Sorry.
What's the shortest amount of time you work with a patient?
Okay. Okay. Oh, well, I mean, I guess maybe 7 days would be the shortest amount of time.
And then another question from the chat as well is, do you ever collaborate with chiropractors? I know, definitely PTs probably collaborates with quite a few different disciplines, and this person's wondering if chiropractors are one of them.
I'll take that. I would say all the time. I think it depends on I think it's going to depend quite a bit on where you are geographically, what your setting is. I used to be in a private practice in Stowe, and there was a chiropractor there who was very, I would say, she was a big advocate of physical therapy, and she was a wonderful collaborator. A lot of people who see chiropractors have sort of long-term relationships with those providers. So, you would never, as a physical therapist, want to tell somebody, well, you don't need to go see that person. And so it's really nice to work together with the providers that the patient values and has already an established relationship with. So yeah, there's a lot of collaboration back and forth.
Thank you. I had a question. I was wondering if you could explain the difference between occupational therapy and physical therapy.
Yeah, so I'll start, and then Allie, you pipe in as well. So there are some similarities. A physical therapist essentially, I think one of the challenges we've had as a profession is that I don't think we have a really well-established identity. I think in terms of public opinion, people think about physical therapists in terms of what they do versus what they know. And we've been trying to improve on that a little bit in terms of our professional identity. And so I'll start with that, which is physical therapists are sort of experts in what they call the movement system. So any system in the body that contributes to human movement, we know about and can tap into those systems and facilitate optimal human movement. So it's all systems: cardiopulmonary, it's musculoskeletal, it's neuromuscular, it's integumentary, it's the skin, it's the genitourinary system. So there are all those component parts that come together that facilitate human movement. As far as an occupational therapist, their focus is a little more toward the functional side of the patient's daily life. There are some things that will overlap a bit, but there's quite a bit in occupational therapists, just as the title says, that really focus on how the patient functions within their environment and can, maybe incorporate a few more of the cognitive aspects of human functioning. There's quite a bit in terms of human development. So there are a lot of occupational therapists are pediatric experts as well. Help me out, Allie.
Okay. Yeah, I think that was good, but no, it was good. From an inpatient side, I think it's a little easier to kind of differentiate between the two. So if you had a patient come in, they ordered PT and OT, right? So me as the PT, I'm coming in, and just like Elizabeth said, I'm looking at gross motor movements. Can the patient get out of bed? Can they transfer? Can they walk? Can they do stairs? So kind of more those big gross motor things. Whereas the occupational therapist will come in and look at more, can the patient get dressed, right? Can they put their shirt on? Can they put their pants on? Can they go to the bathroom? Can they get in the shower? So it's more kind of those activities of daily living tend to be a little bit more fine motor, where kind of PTs do a little bit more of the gross motor. But I would agree with Elizabeth, there is a lot of overlap in what we do. But that kind of, I think, helps differentiate between the two professions.
And it's another source of some amazing collaboration.
Thank you both. Kind of just, it's semi related to this, but I was wondering if you could kind of talk about some of the things that you look for in your assessments when you're consulting on a patient, or you're called in for an evaluation, kind of like those steps or major things that you go through with a patient.
Okay. I can start in terms of the outpatient orthopedic setting, and then toss it to Allyson about the inpatient neuro, or if you like. So for me, starting off, basically, patient walks in the door, I have no information. So we sit down, and the patient will start to describe to me why they're here to see me. So 9 times out of 10, it's pain. They have pain somewhere. And 90% of the diagnostic process, and this is probably true in medicine as well, but there's the diagnostic process primarily happens during the subjective exam. It's pattern recognition. You're screening for red flags. You're trying to determine whether or not the source of their complaint is truly musculoskeletal. Does it fall within the scope of my care? Or what they're describing could be possibly due to something a little bit more sinister. So, we're screening for any kind of systemic issues, metastatic processes, fracture, infection, all these things that would require physician referral. And as long as we can screen out those things, then we design a clinical exam based on what they've told us in the subjective part. So a lot of us will start with just watching somebody move. If they say, oh gosh, I have a lot of difficulty doing, this type of movement, I'll say, okay, show me what that looks like. And from there, from that movement observation, I can determine, okay, here's what looks like their functional deficit. Now let's break that down a little bit. So if they say, I can't pick anything up off the floor, I'm going to watch them forward bend. I'm going to measure their lumbar range of motion. I'm going to look at their hip motion. I'm going to test their sensation and their strength and their reflexes, make sure their nervous system is functioning. There are special tests that possibly could add to that diagnostic process. But a lot of what we can determine is based on just watching somebody move and testing for really fundamental things like mobility, strength, sensation. And then based on what their limitations are, then we design our plan of care from there. Did that answer the question, Lily?
Yeah, that did.
Okay. And then go ahead, Allyson.
Oh, well, you did such a nice job. So I guess, speaking from like an inpatient or even just a neuro lens, I mean, it's very similar, right? So typically with a neuro population, we don't do the medical diagnosis of, stroke or, MS or Parkinson's, whereas from Elizabeth's lens, they're doing a little bit more of the diagnosis from an orthopedic standpoint, but it's very similar, right? So even if you have a patient who had a stroke, it doesn't really matter. My goal is really to watch the patient move and see why they're moving the way they're moving, right? So if they're not walking as well as they should be, well, why is that? And being able to kind of break down the movement, whether it's a transfer, whether it's walking, whether it's doing the stairs, and then really figuring out the root of the problem, and then kind of tailoring your exam and tailoring your intervention to improve those deficits, to make their walking better, to make the stairs better, to make the transfers better. So that's kind of how I break it down from my lens, but it's very much the same across whether you specialize in orthopedics, neuro, cardiopulm.
Thank you. And then one more question, and we'll move on to the case study. I wanted to know, especially when working with patients who've recovered from terrible injuries or really unfortunate circumstances, do you have a special skill set you use when you're working with patients who are in a lot of pain or are resistant to treatment? And then how do you take care of your mental health as well, being in those settings?
That's a great question, especially because, patients in pain, particularly patients who have chronic pain, there can be a lot of emotional distress there. So I think there are a couple of things that can be quite helpful. There's a lot of reassurance that goes on, particularly if somebody hasn't been to physical therapy before. A lot of patients may kind of bounce around the medical system a little bit, and that's usually kind of red flag number one. Lots of imaging, lots of opioids, all kinds of things that we know are not effective and lead to poorer outcomes. So anyway, it's kind of trying to understand from them where they are in terms of what do they think is going on, what do they and so what you can do is uncover any kind of maladaptive beliefs as far as pain goes. Reassure patients that, particularly chronic pain patients, or patients with chronic pain, I should say, that oftentimes the tissue healing has occurred. There's some nervous system hypersensitivity and hypervigilance that we can address, but pain doesn't necessarily equal harm, and really encouraging them to move. So they're actually doing quite a bit of study now, looking at, do you really need to myth bust, or can you just provide education? And I think you can just sort of gently guide people. I don't think you need to try to correct anyone's maladaptive beliefs. You can just kind of gently steer them in the right direction. As far as taking care of my own mental health, I think as a young novice practitioner, that was much more challenging because I was under the false impression that everybody's problem was mine to fix. And I think as an experienced clinician now, what I recognize is that there are a lot of people I can help. I can't help everybody. And determining when I've reached sort of the limit of what I can provide and looking for the appropriate referral. Sometimes that's another PT. Sometimes it's identifying another physical therapist with a different skill set than what I have. Sometimes it's a mental health provider. Sometimes it's social services. Sometimes it's helping the patient uncover their own social network that might provide the support to facilitate them moving more. So I'll toss it to Allyson.
I'll just add one piece. I think when you talk about, communicating with your patients, there's not really a cookie cutter answer. You have, as a physical therapist, or really even as just a healthcare provider in general, you have to be able to read a person pretty quickly, right? Like as soon as you start talking to the patient, you kind of need to figure out how you're going to adjust your communication, where you have some patients who you can be very assertive, right, and kind of come in and be a little bit more forceful, whereas you have some patients who are a little bit more sensitive, where you have to kind of be a little bit more encouraging, and maybe taking a little bit more time to kind of just sit and listen and let them decompress or vent or whatever they need to do. And then I think Elizabeth said it well, for mental health, it's very challenging being in the healthcare profession, because if you choose a healthcare profession field, you do feel responsible to take care of all your patients, and all you want is your patients to do well, and you do take a lot of that on. We all do, because we're human. The biggest thing for me is to always just at the end of the day, just take a step back and realize that if I take all that stuff home with me, then my mental health suffers and then my patients suffer, because I can't give them what they actually need. So trying to kind of reframe what your purpose is, that you're not there to fix all the problems, but you're there to show up and be there for your patients, that has kind of helped me avoid some of the burnout.
Thank you so much. And so we'll have a little more time at the end to answer any final questions, but for now we'll move on to the case study portion and let you two take it away.
So I'm not really sure where you want to go with this, but I guess I'll just kind of give some background. Is that kind of what you want me to start with? Okay. So this is a patient, I worked with this patient at the Mayo Clinic when I was doing my residency. He, middle-aged man. So basically he fell off a ladder at home, and he had a traumatic brain injury. So he had a brain bleeding in his brain. And when he came in, he had so much swelling that they had to do a craniectomy. And for those of you who don't know what a craniectomy is when you have so much swelling in the brain, secondary to trauma, they actually have to remove half your skull. So he had his skull flap removed, and it was actually off for a long period of time, because it takes the brain a long time to kind of reduce the swelling. And so he had to wear a helmet. And so a lot of times when you have traumatic brain injury, you kind of go through phases, the recovery process. So when I first met him, I was actually on inpatient rehab. So I didn't see him in his hospital room. I saw him, the day he came to inpatient rehab, where I spent an hour with him every day for probably, I would say, 4 weeks. And so when I first met him, he was super agitated, very inappropriate, combative, didn't know where he was, needed a lot of redirection and cues, which is very common for traumatic brain injury. But it's just very overwhelming. It can be very overwhelming. And, the biggest thing is just trying to figure out where he's at and what he needs in order to be able to get home. And so the reason I really like this case is because it took so many of us to be able to give him good quality care. He had a PT, he had an OT, he had a speech language pathologist. We had to call in the neuropsychologist, and we all had to kind of work together. We would meet every day about this patient and figure out what the goals were, right? And so I had to bring my goals to the table of, this is what he needs for PT, right? And everyone is kind of bringing up their own goals. And so he was very aggressive verbally, in that he didn't really want to do anything, didn't want to listen to anybody. We had to have signs in his room, saying, you are at the hospital, you had a fall. I got very close with his wife, because she was, had permission to be there pretty much 24/7, and just a lot of education to the wife, to the family, because it's a very big change when you have a loved one who has a personality that is not really them. And so it was really great, because he was so challenging when I first met him, and he was such a pain. Every morning I would have to go into work, and I was so I don't know what to do with him. But I never gave up on him. And that's what he always, he literally just texted me yesterday. We still talk all the time. And, he always talks about my ability to connect with him push him and really give him a sense of empowerment. And that's really why I like this case, because as a healthcare provider, whether it's PT or anything in the healthcare field, I don't think people realize how much influence we have over other people's lives. I think we get so immune to it because we see so many patients every day, but we are definitely few and far between for each patient. And we just really have the ability to make a big difference. So he started out, he could barely get out of bed. I think it took two of us to get him sitting up at the edge of the bed. He couldn't even stand, when he came in. And then my last week of working with him, we used to take walks outside on the grass. He bought me coffee on my last day. We walked across the street to a coffee shop. So to kind of see this big change in a short amount of time, it's hard work on both the patient and the therapist end, but the reward is totally worth it. So wanted to share that case with you guys. Yeah. And just really, it definitely takes a team. Anytime you work with a patient, especially a patient with neurological impairments, it's never just the PT. You've got a whole slew of people who you need to continuously collaborate and communicate with, because even though we have this degree that allows us to treat patients without referral, we can't do our job without the support of other healthcare professions. And that goes really for any healthcare profession. No one can really do it by themselves. So that's Brent. So I have permission to share his story, and obviously his story made the newspaper. So this is when he was in the ICU, and his daughter, he was supposed to be at his daughter's wedding, and obviously he missed it. And his daughter actually got married in the ICU. The sad part is he doesn't remember the wedding, but they took lots of pictures, and so he has a grandson now, and he's back to playing guitar. He sent me his guitar recording a couple weeks ago, and they just are a very beautiful family, and he made a full recovery.
Thank you so much, Allison. Just quickly before we start, I just wanted to say, as I personally have had experience just working on an inpatient floor and seeing the physical therapists and occupational therapists work with patients, and they truly are, patients' biggest cheerleaders, and they always come with such incredible attitudes, and I think it just makes such a huge difference. So I really, commend the two of you for the field that you work in, and you really do make such huge differences in patients' lives, and form these incredible connections with them. I think you're in a really unique field where you have so much of that one-on-one patient interaction that a lot of people who go into healthcare really appreciate and really look for.
Thank you.
Thank you.
Oh yeah, go ahead, Julian.
A quick question, just what do you recommend for young students who are interested in going into physical therapy?
I think the more people you can talk to, the better. I mean, if any of you are really interested in PT, what you're doing tonight this is definitely the first step. I think it's really great to just talk to a lot of different people. And I think PT is awesome because you can do so much with it. There's so many different avenues, and there's always, as a healthcare provider, we're lifelong learners. And obviously you can tell that Elizabeth and I love to learn, right? Like we just seem to keep going. And so I think that's really the first step. And then any chance you can get at any kind of shadowing opportunities and getting into a clinic and into a place that you think you might want to be at might help you kind of solidify your answer a bit.
Yeah, I would say just, try to uncover as much information as you possibly can by talking to people. Like Allison said, really look into lots of different settings. We get so many physical therapy students who have only had exposure to the outpatient orthopedic setting. And when they graduate, inevitably 9 times out of 10, they're telling us, I had no idea all of the different things that physical therapists do and all the different settings they can work in. And so and it's just such a beautiful thing. So, I would say, really shore up on your science education, and talk to as many people as you can, and even just, explore different physical therapy practices, different types of settings, and approach PTs, cold call them, email them. A lot of PT practices will have, staff emails, and just say, hey, would you mind if I asked you some questions? We're pretty approachable people.
I had
Thank
sorry.
Go ahead.
I had a really quick question going off of that. I'm Ruby, by the way. But I was wondering, with the shadowing process, or for students interested in getting involved, how does this case study kind of reminded me of that, but with the patients, especially people suffering from neurological illnesses or injury, how does it work with getting kind of the permission is it easy to bring students into shadow, or is it more case by case? Like, for people who are interested in that specifically, has it been easy to bring people in, get experience, or is it harder with those particular cases? If that makes sense.
Yeah. So if you want to shadow, I mean, it really kind of depends on the facility. And Elizabeth, you can jump in and correct me if I'm wrong, but I just remember I would just call facilities, and then I kind of had to see if it would be something that they were interested in taking me on. And sometimes when you go to hospitals, there's a little bit more cookie cutter process to get in there. So you would have to just kind of call based on maybe a clinic that you're interested in observing. From a patient standpoint, 9 times out of 10, they love students. They love sharing their story. When I texted Brent to ask him if I could talk about him, he wanted to come. He just they love to, anything that they can do, to help with students learning, clinicians learning. From my experience, most of the time, patients are very much willing to kind of have you guys there. So.
Yeah, and believe it or not, I think the most time I had spent in an inpatient rehab setting pre-PT school, I was employed there as an aide, as a rehab aide. So that's, you could always, if you have that kind of time and have the availability in your schedule for something like that, I think that is probably one of the best ways that you can gain exposure to it. But I think a lot of hospital settings are open to students being in their clinic spaces, particularly teaching hospitals. So COVID definitely messed with that a little bit, but I think that's gotten better. Most, if not all, healthcare settings are still observing some pretty good precautions as far as that goes.
Thank you. And then I know we're going to be wrapping up here pretty soon, and we just like to ask all of our panelists what your favorite thing about working at UVM Medical Center is, or, working with the Vermont population in particular.
Boy, I would definitely say Vermonters are hardy folk. I used to work in a clinic up near the Canadian border, and farmers were some of my favorite people to treat. I couldn't treat them for long because they had just no patience or time to be injured. And they just said, okay, that's good enough. I got it. And they would heave ho out the door and go back to work. And then similarly, just a lot of very active older people. I've treated a lot of masters athletes. I had an 80-year-old woman who had her knee replaced and told me I needed to get her back in shape because she was about to jump out of a helicopter. She's going to go heli skiing in the Bigaboos, and I had to get her ready. And I said, okay, so it's just a really fun group of tough old birds to work with.
Well, I'm relatively new to the Vermont area, but I would say the thing that I'm most excited about is, like Elizabeth said, because we have there's such an active community here. There is a very big adaptive sports program, and obviously, since I'm more interested in the neuro population, I am very much excited to kind of get involved with the adaptive sports community.
Well, thank you both so much for being here tonight and sharing your stories and giving us a little bit of a look into the world of PT. Please join us next month for our session, October 20th. We'll be spotlighting emergency medicine, and we're excited for this academic school year. Thank you, everyone, for coming.
Thank you,
for
everyone,
having
for
us.
joining us tonight. And thank you
Thank
to
you.
our panelists. We hope you all have a great rest of your evening.
Thank you.
Thank you.